One wrong decision in a cardiac emergency can change a patient's outcome within seconds. Many CCRN candidates lose valuable exam points because they memorize numbers without truly understanding what those values mean in real critical care situations. In this complete study guide, you'll learn how to think like a critical care nurse, recognize dangerous patterns quickly, and confidently answer challenging CCRN exam questions. Be sure to download the free CCRN study guide with the most important exam questions from the description to review alongside this lesson. Now, let's begin with one of the most heavily tested topics on the CCRN exam, the cardiovascular system and hemodynamics. In this section, you'll learn how to evaluate heart function, interpret essential hemodynamic values, recognize life-threatening cardiac conditions, and understand the clinical reasoning behind every decision. By the end of this lesson, complex cardiac concepts will become much easier to understand, giving you the confidence you need for both the CCRN exam and real-world critical care practice. To truly understand critical care cardiology, we must first visualize how blood flows through the heart and the lungs. Deoxygenated blood returns from the body into the right atrium, travels down into the right ventricle, and is pumped into the lungs to receive oxygen. The freshly oxygenated blood then travels to the left atrium, drops into the left ventricle, and is strongly pushed out through the aorta to feed the entire body. Remembering this simple pathway is your key to unlocking where fluid backs up when a specific part of the heart fails. The most important measurement of overall heart performance is cardiac output, which tells us how much blood the heart pumps in one full minute. You can easily calculate cardiac output by multiplying the heart rate by the stroke volume, which is the amount of blood ejected with each single heartbeat. A normal cardiac output is typically between 4 and 8 liters per minute, ensuring that all vital organs receive enough oxygen to survive. If either the heart rate or the stroke volume drops too low, the patient will quickly show signs of poor perfusion, such as confusion or decreased urine output. Since stroke volume is such a huge part of cardiac output, you need to understand its three main components, which are preload, afterload, and contractility. Think of these three elements as the volume, the resistance, and the squeeze of the heart muscle. When a patient is unstable, your medical interventions will directly target one or more of these three areas to improve blood flow. We will look at each of these components individually so you know exactly how to manipulate them in a clinical setting. Preload is simply the amount of stretch inside the heart muscle right before it contracts, and it is heavily determined by the volume of blood returning to the heart. If a patient is dehydrated or actively bleeding, their preload will be dangerously low, and they will need intravenous fluids or blood products. Conversely, if a patient is experiencing heart failure, their preload might be too high, meaning they have too much fluid and will likely need diuretics to remove the excess water. On your exam, you will look at the central venous pressure to assess right-sided preload, and the pulmonary artery occlusion pressure to assess left-sided preload. Afterload represents the resistance that the heart must push against to eject blood out into the blood vessels. Imagine trying to blow air through a tiny cocktail straw instead of a wide tube, and you will understand how high resistance makes the heart work much harder. If the blood vessels are tightly constricted, the afterload is high, and you might need to administer vasodilating medications to relax the vessels and lower blood pressure. On the other hand, if a patient is in severe shock with relaxed vessels, you will use vasopressors to tighten those vessels and increase the afterload to keep the patient alive. Contractility is the actual physical strength of the heart muscle as it squeezes during each beat. If the heart muscle is damaged from a massive heart attack, the contractility will be very weak, and the stroke volume will drop significantly. To help a struggling heart squeeze harder, we use a class of continuous intravenous medications called positive inotropes, with dobutamine being a classic example you will see on the test. Improving contractility helps push more blood forward, but it also forces the heart to consume more oxygen, which is a delicate balance you must manage carefully. To measure all these hemodynamic values accurately, critical care nurses rely on advanced tools like arterial lines. An arterial line is a small catheter placed directly into an artery, usually in the wrist, that provides a continuous, real-time blood pressure reading on your monitor. For this reading to be perfectly accurate, you must ensure the monitoring system is leveled exactly to the phlebostatic axis, which represents the physical location of the right atrium. You must also perform a zeroing procedure to eliminate the effects of atmospheric pressure, ensuring the numbers you see are true and safe to base your medication changes on. For the most complicated patients, doctors might insert a pulmonary artery catheter, also known as a Swan-Ganz catheter, which travels through the right side of the heart and rests in the pulmonary artery. This specialized yellow catheter allows you to directly measure continuous cardiac output, right heart pressures, and left heart filling pressures. While these devices provide incredible amounts of data, they also carry high risks, such as causing dangerous heart rhythms during insertion or potentially rupturing the pulmonary artery. You will need to know both the normal numerical values provided by this catheter and the safety protocols for managing it at the bedside. Moving into cardiac emergencies, acute coronary syndrome is an umbrella term that describes a sudden reduction in blood flow to the heart muscle. This condition ranges from unstable angina, where the heart is crying out for oxygen, all the way to a massive myocardial infarction, where heart tissue is actively dying. Your immediate nursing goals are to restore blood flow, decrease the oxygen demand of the heart, and manage the intense chest pain your patient is experiencing. Time is muscle, meaning the faster you intervene, the more heart tissue you can ultimately save. The electrocardiogram, or ECG, is your primary tool for quickly identifying acute coronary syndrome and guiding emergency treatment. When looking at the tracing, you must pay close attention to the Saint segment, as a noticeable elevation indicates a complete blockage of a coronary artery, known as a STEMI. If the ST segment is depressed or the T wave is flipped upside down, the patient might be experiencing severe ischemia or a partial blockage, known as a non-STEMI. The exam will expect you to know which specific leads look at which specific walls of the heart to identify exactly where the damage is occurring. A right ventricular infarction is a unique type of heart attack that requires a completely different treatment strategy than a standard left-sided heart attack. When the right ventricle is damaged, it loses its ability to pump blood forward into the lungs, causing fluid to back up into the systemic circulation and dropping the overall blood pressure. Because this damaged right heart relies heavily on high fluid volume to push blood forward, you must absolutely avoid giving medications like nitroglycerin or morphine that lower preload. Instead, these patients usually require aggressive intravenous fluid boluses to maintain their cardiac output and blood pressure. Heart failure is another massive topic on the exam, and it is usually divided into left-sided and right-sided failure, each presenting with very different symptoms. Left-sided heart failure means the left ventricle cannot effectively pump blood out to the body, causing fluid to back up directly into the lungs. Your patient will present with severe shortness of breath, a wet cough, crackles when you listen to their lungs, and dangerously low oxygen levels. This condition, known as acute pulmonary edema, requires immediate interventions like supplemental oxygen, diuretics, and medications to help the heart squeeze better. Right-sided heart failure occurs when the right ventricle fails, which forces fluid to back up into the venous system of the entire body. These patients will develop dramatic swelling in their legs, an enlarged liver, and noticeably bulging jugular veins in their neck. Often, right-sided heart failure is actually caused by chronic lung diseases or severe left-sided heart failure that has created too much pressure in the pulmonary system over time. Treating this condition involves carefully managing fluid balance and treating the underlying lung or left heart problem that caused the high pressure in the first place. When heart failure becomes so extreme that the heart cannot sustain life, the patient enters a deadly state known as cardiogenic shock. In this condition, the cardiac output is terribly low, the blood pressure plummets, and the organs begin to fail from lack of oxygen, even though the body has plenty of fluid. Treating cardiogenic shock is incredibly challenging because giving fluids will only make the weak heart work harder, while giving medications to raise blood pressure can clamp down vessels and increase afterload. You will have to expertly balance inotropes to help the squeeze, carefully manage vasodilators if blood pressure allows, and prepare for mechanical support. When medications are not enough to save a failing heart, you might need to manage mechanical assist devices, like the intra-aortic balloon pump. This device features a long balloon sitting inside the descending aorta that inflates and deflates in perfect synchronization with the patient's cardiac cycle. The balloon rapidly inflates while the heart is resting, which pushes blood backward into the coronary arteries to feed the heart muscle with extra oxygen. It then instantly deflates right before the heart squeezes, creating a vacuum effect that drastically lowers afterload and makes it much easier for the weak heart to empty. Hypertensive crises are another common emergency where the blood pressure skyrockets to incredibly dangerous levels, putting immense stress on the entire vascular system. We differentiate between hypertensive urgency, where blood pressure is high without organ damage, and hypertensive emergency, where the high pressure is actively causing a stroke, heart attack, or kidney failure. In an emergency, your goal is not to drop the blood pressure to perfectly normal levels immediately, because doing so could dangerously shock the brain and organs. Instead, you will use fast-acting continuous intravenous drips, like nitroprusside or labetalol, to slowly and safely lower the pressure over several hours. Uncontrolled high blood pressure is a leading cause of aortic aneurysms and dissections, which are absolute medical emergencies requiring rapid recognition. An aneurysm is a ballooning weak spot in the wall of the aorta, while a dissection occurs when the inner lining tears, allowing blood to aggressively rip through the layers of the blood vessel. A patient with a dissecting aorta will describe sudden, severe, tearing pain in their chest or back, and their life is in immediate danger. Your priority is to aggressively lower their blood pressure and heart rate to prevent further tearing while the surgical team prepares for an emergency operation. Finally, you must be highly skilled at identifying and managing dangerous heart blocks on the cardiac monitor, which occur when electrical signals get delayed or stopped entirely. A first-degree block is usually harmless, but second-degree blocks can cause the heart rate to drop and require close observation. A third-degree heart block, or complete heart block, is a lethal rhythm where the top and bottom of the heart completely stop communicating, leading to a profound drop in heart rate and cardiac output. For symptomatic heart blocks, you must be ready to administer atropine, or more likely, apply transcutaneous pacing pads to externally force the heart to beat at a safe rate. Congratulations on completing this first and incredibly important section on the cardiovascular system and hemodynamics. I highly encourage you to immediately complete the attached practice test for this section, as answering realistic questions is the absolute best way to improve your retention and measure your exam readiness. Practice questions force you to apply what you just learned, and this active learning process is what truly builds your confidence, which is why a targeted test is included with this lesson. Once you feel comfortable with how the heart pumps and how we monitor those pressures, you will be perfectly positioned to understand how oxygen gets into the blood in the first place. I look forward to seeing you in the next section, where we will conquer the respiratory system and mechanical ventilation together. Welcome to the second section of our course, focusing on the respiratory system and mechanical ventilation. You will learn how to identify acute respiratory failure, interpret blood gases, and safely manage patients on breathing machines. This knowledge is necessary because airway emergencies are among the most common and life-threatening scenarios you will face as a critical care nurse. Get ready to build a solid foundation in pulmonary medicine that will make you feel highly capable at the bedside. Let us explore how we can help our patients breathe easier. To begin, we must review the basic mechanics of how oxygen enters the blood and how carbon dioxide exits the body. When a patient inhales, air travels down the trachea and deep into the lungs until it reaches tiny air sacs called alveoli. These microscopic sacs are surrounded by blood vessels, and this is the exact location where gas exchange happens. If these alveoli become filled with fluid or collapse entirely, the patient will struggle to get oxygen into their bloodstream regardless of how fast they breathe. Acute respiratory failure happens when the lungs suddenly cannot do their job, and we categorize this into two distinct types. The first type is hypoxemic respiratory failure, which simply means there is not enough oxygen in the blood. This usually occurs when conditions like pneumonia or pulmonary edema flood the alveoli, creating a physical barrier that blocks oxygen from crossing over into the blood vessels. You will notice these patients breathing very fast and appearing highly anxious as their bodies become desperate for air. The second type is hypercapnic respiratory failure, which means the body is failing to blow off enough carbon dioxide. This problem is typically caused by a failure of the ventilation process itself, such as a drug overdose suppressing the drive to breathe or extreme muscle weakness. As carbon dioxide builds up in the bloodstream, it acts like a powerful sedative, causing the patient to become increasingly sleepy and confused. Your primary treatment goal here is to help the patient move more air in and out to clear the retained gas. An arterial blood gas, or ABG, is the gold standard laboratory test you will use to evaluate a patient's respiratory status. This test involves drawing blood directly from an artery to measure the precise levels of oxygen, carbon dioxide, and overall blood acidity. By analyzing these numbers, you can determine exactly what type of respiratory failure is occurring and whether your current treatments are working. You must become highly comfortable reading these results, as exam questions frequently require you to interpret an ABG before choosing the correct nursing intervention. When interpreting a blood gas, you will always look at the pH level first to determine if the blood is acidic or alkaline. A normal pH falls strictly between 7.35 and 7.45, and any number below 7.35 indicates a state of acidosis. Next, you evaluate the carbon dioxide level, which normally rests between 35 and 45 millimeters of mercury. Because carbon dioxide functions as an acid in the body, a high level will directly cause the pH to drop, resulting in a condition known as respiratory acidosis. After looking at the carbon dioxide, you must assess the bicarbonate level, which is managed by the kidneys and acts as a base. Normal bicarbonate ranges from 22 to 26 milliequivalents per liter, and the kidneys will adjust this level to help balance the blood pH. If a patient has been in respiratory acidosis for a few days, you will see the bicarbonate number rise above normal as the kidneys attempt to compensate and fix the acidity. Understanding this compensation mechanism is a common testing point on your certification exam. Acute respiratory distress syndrome, commonly called ARDS, is one of the most severe lung conditions you will manage in critical care. It occurs when a systemic illness, like massive trauma or widespread infection, causes inflammation that damages the tiny blood vessels in the lungs. This damage allows fluid and proteins to leak directly into the alveoli, completely washing out the protective surfactant that keeps the air sacs open. The lungs quickly become stiff, heavy, and practically useless for gas exchange, creating a true medical emergency. Treating ARDS requires a very specific approach to mechanical ventilation because the lungs are extremely fragile and easily damaged by high pressures. You will use low tidal volumes, meaning you only push a small amount of air into the lungs with each breath, to prevent stretching and popping the stiff alveoli. To keep the fluid-filled alveoli open, you will also apply high levels of positive end expiratory pressure, or PEEP. This continuous pressure holds the air sacs open at the end of each breath, giving oxygen more time to cross over into the bloodstream. When standard ventilation strategies fail to improve oxygen levels in ARDS, you will likely need to place the patient in the prone position. Flipping a patient onto their stomach physically takes the weight of the heart and abdominal organs off the back areas of the lungs. Because the majority of our lung tissue is located in our back, this maneuver suddenly opens up thousands of collapsed alveoli for fresh gas exchange. Proning requires a highly coordinated team effort, but it is a proven method for saving lives when oxygen levels drop dangerously low. When a patient can no longer breathe safely on their own, we must place a breathing tube down their trachea and connect him to a mechanical ventilator. The ventilator is simply a machine that pushes air into the lungs under pressure and then allows the lungs to passively deflate. You can set the machine to deliver a guaranteed number of breaths per minute, a specific volume of air, and a precise percentage of oxygen. Your job is to constantly monitor the patient to ensure the machine is actually helping him rather than causing further harm. Assist control is one of the most common ventilator modes you will use for patients who need maximum breathing support. In this mode, the machine delivers a preset volume of air every time it gives a breath, whether that breath is initiated by the machine or by the patient. This guarantees that the patient receives a full, deep breath every single time, which is excellent for resting tired breathing muscles. However, if the patient becomes anxious and starts breathing very fast, they can easily hyperventilate and blow off too much carbon dioxide. Synchronized intermittent mandatory ventilation, or SIMV, is another mode you must understand for both clinical practice and testing. This setting delivers a minimum number of guaranteed breaths at a set volume, but it allows the patient to take their own spontaneous breaths in between. The machine does not force a full volume of air during those extra spontaneous breaths, so the patient determines the size of their own extra breaths. This mode exercises the breathing muscles and is frequently used as a step-down approach when preparing a patient for eventual extubation. Pressure support is a completely spontaneous breathing mode where the patient dictates their own respiratory rate and the size of every breath. The ventilator simply provides a small boost of pushing pressure during inhalation to help overcome the resistance of breathing through a long plastic tube. We use this mode primarily to test if a patient is strong enough to breathe entirely on their own before we remove the breathing tube. If a patient can maintain good oxygen levels and a normal breathing rate on pressure support, they are likely ready for extubation. Managing ventilator alarms is a major part of your daily nursing routine, and you must know how to troubleshoot them instantly. A high-pressure alarm sounds when the machine encounters excessive resistance while trying to push air into the lungs. This resistance is often caused by the patient biting on the breathing tube, thick mucus blocking the airway, or a sudden lung collapse. You should immediately assess the patient, suction their airway if necessary, and ensure the breathing tube is not kinked or obstructed. Conversely, a low-pressure alarm indicates that the air is flowing too easily, meaning there is a leak somewhere in the closed system. The most common cause is the breathing tube simply popping off the ventilator circuit, which instantly stops the delivery of life-saving oxygen. Another frequent cause is a leak around the inflated cuff of the breathing tube sitting inside the patient's trachea. You must immediately trace the plastic tubing from the machine to the patient to find the disconnection and securely reattach it. Ventilator-associated pneumonia is a deadly complication that occurs when bacteria travel down the breathing tube and infect the lungs. Preventing this infection is a major focus on the certification exam and relies heavily on excellent basic nursing care. You must keep the head of the bed elevated at all times to prevent stomach contents from sliding up and into the airway. Additionally, you must perform frequent oral care using antiseptic solutions to keep the mouth clean and reduce the amount of bacteria available to travel downward. A pulmonary embolism is a sudden blockage in a lung artery, usually caused by a blood clot that traveled upward from a deep vein in the leg. This blockage creates a massive problem because air is still moving into the lungs normally, but blood can no longer reach those air sacs to pick up the oxygen. The patient will experience a sudden onset of chest pain, shortness of breath, and a rapidly dropping oxygen saturation. Treatment focuses on supporting breathing while quickly administering blood thinners to stop the clot from growing any larger. Chest tubes are plastic drains surgically inserted through the ribs into the pleural space to remove trapped air, fluid, or blood. This space normally acts as a vacuum to keep the lungs pulled open against the chest wall, but trapped air or fluid ruins that vacuum and causes the lung to collapse. You must monitor the drainage system carefully, ensuring there are no uncontrolled air leaks and that the fluid output is not excessive. Never clamp a chest tube without a specific medical order, as doing so can cause a fatal buildup of pressure inside the chest cavity. Congratulate yourself on finishing this challenging section on the respiratory system and mechanical ventilation. I strongly encourage you to complete the attached practice test right now to see how well you grasp these concepts. Completing practice questions is the absolute best way to improve your retention and measure your true exam readiness. This included quiz will help you practice active learning and solidify your understanding of ventilator modes and blood gas interpretation. Keep up this great momentum as we naturally transition into the next section, where we will explore neurological emergencies, renal function, and gastrointestinal care. Welcome to the third section of our complete study guide, where we will focus on the neurological, renal, and gastrointestinal systems. In this lesson, you will learn how to assess brain function, manage kidney failure, and treat life-threatening digestive emergencies. Understanding these interconnected organs is crucial for the exam, as a failure in one system rapidly causes cascading damage in the others. Get ready to expand your clinical knowledge, because by the end of this video, you will know exactly how to protect these delicate structures. Let us jump right in and start with the brain. We will begin with the concept of intracranial pressure, which is the amount of force pushing inside the skull. The skull is a rigid, closed box that contains exactly three things, which are brain tissue, blood, and cerebrospinal fluid. Because this bone box cannot expand, an increase in any of these three components must force something else out, or the internal pressure will rise. Normal pressure rests between 0 and 15 millimeters of mercury, and any sustained elevation can cause permanent brain damage. When the pressure inside the head becomes dangerously high, the swollen brain tissue has nowhere to go but down towards the brainstem. This downward shifting is called herniation, and it is a fatal event that immediately stops the body from breathing and regulating the heart. As a nurse, your primary goal is to prevent this catastrophic shifting by recognizing the early warning signs of rising pressure. A subtle change in the level of consciousness, such as a patient becoming unusually sleepy or confused, is often your very first clue. If you miss those early signs, the patient will eventually present with a late and ominous set of symptoms known as Cushing's triad. This triad consists of a widening pulse pressure, a significantly slowed heart rate, and an irregular breathing pattern. When you see these three signs together, it means the brainstem is actively being crushed and the patient is nearing the point of herniation. You must act immediately to reduce the pressure by notifying the physician and preparing rapid medical interventions. To quickly lower pressure inside the skull, we use hyperosmolar therapy, primarily relying on a medication called mannitol or a concentrated hypertonic saline solution. These heavy intravenous fluids act like a sponge in the bloodstream, pulling excess water out of the swollen brain tissue and into the blood vessels to be urinated away. You will also keep the head of the bed elevated at 30 degrees and ensure the patient's neck is straight. This physical positioning allows gravity to help drain venous blood away from the head, directly reducing the volume inside that tight space. Moving to stroke management, an ischemic stroke occurs when a blood clot physically blocks an artery in the brain, starving the tissue of oxygen. Time is the most pressing factor here, and you must rapidly determine exactly when the patient was last seen entirely normal. If the patient arrives at the hospital quickly enough, they might be eligible to receive a powerful clot-busting medication called alteplase. This medication can dissolve the blockage and restore blood flow, but it carries a high risk of causing bleeding in other parts of the body. The other type of stroke is hemorrhagic, which happens when a weakened blood vessel bursts and bleeds directly into the brain tissue. This sudden bleeding rapidly increases the pressure inside the skull and destroys the surrounding delicate neurons. Giving a clot-busting drug to a patient with a bleeding stroke would be deadly, which is why a rapid computed tomography scan is always required first. Your main focus for a bleeding stroke is to keep the blood pressure strictly controlled to prevent the hemorrhage from getting worse. Shifting our attention to the kidneys, acute kidney injury is a sudden loss of kidney function that leads to a buildup of waste products in the blood. We generally divide this injury into three categories based on where the problem originates, which are prerenal, intrarenal, and postrenal causes. A prerenal cause means something is preventing blood flow from reaching the kidneys, such as dehydration or a very low blood pressure. Restoring that blood flow quickly with intravenous fluids can often reverse a prerenal injury before permanent damage occurs. An intrarenal injury means the physical tissue of the kidney itself has been damaged, often by toxic medications, contrast dye from imaging scans, or a prolonged lack of blood flow. This type of damage takes a long time to heal and requires careful management of fluids and electrolytes while the kidneys slowly recover. A postrenal injury is caused by a physical blockage occurring after the kidneys, such as a large stone or an enlarged prostate, preventing urine from leaving the body. Removing the physical blockage usually solves the postrenal issue and allows normal urinary function to return. When the kidneys fail, they can no longer filter out potassium, leading to a dangerous buildup called hyperkalemia. High potassium levels are extremely irritating to the electrical system of the heart and can quickly cause lethal cardiac rhythms. You will monitor the electrocardiogram closely for peak T waves, which are a classic early sign of this electrolyte imbalance. Treatments involve giving insulin and dextrose to push potassium back into the cells, or administering medications that bind to the potassium and remove it through the bowels. For critically ill patients with profound kidney failure, traditional dialysis is often too aggressive and causes their blood pressure to drop dangerously low. Instead, we use continuous renal replacement therapy, which is a gentle, slow form of dialysis that runs continuously 24 hours a day. This machine slowly removes waste products and excess fluid from the bloodstream without causing sudden, shocking shifts in fluid volume. Managing this continuous therapy is a complex nursing skill that requires you to frequently monitor coagulation times and balance hourly fluid removal targets. Now let us transition into the gastrointestinal system, starting with acute gastrointestinal bleeding, a very common intensive care emergency. Upper bleeds occur in the stomach or esophagus and often result in the patient vomiting bright red blood or material that looks like dark coffee grounds. Lower bleeds happen in the intestines or colon, usually producing dark, tarry stools or bright red blood escaping from the rectum. In either scenario, the patient is losing valuable volume, and your immediate priority is to support their blood pressure and replace the lost fluids. One of the most terrifying types of upper bleeding comes from esophageal varices, which are enlarged, fragile veins lining the lower esophagus. These swollen veins are typically caused by liver cirrhosis, which creates high pressure in the blood vessels attempting to flow through the hardened liver. When one of these varices ruptures, the patient can bleed to death in a matter of minutes. Treatment requires rapid fluid replacement, administering blood products, and preparing the patient for an emergency endoscopy to physically band the bleeding veins. Speaking of liver cirrhosis, acute liver failure creates systemic chaos because the liver performs hundreds of essential functions for the body. When the liver fails, it can no longer manufacture clotting factors, meaning the patient will bruise easily and bleed from minor injuries. It also loses the ability to filter toxins like ammonia from the bloodstream, leading to a confused and combative state known as hepatic encephalopathy. You will frequently administer a medication called lactulose, which binds to the toxic ammonia and forces the patient to excrete it through their stool. Acute pancreatitis is another intensely painful gastrointestinal emergency where the pancreas essentially begins to digest itself. This organ produces powerful digestive enzymes, and if a gallstone or heavy alcohol use traps these enzymes inside, they actively attack the pancreatic tissue. The pain is usually located in the upper abdomen and radiates straight through to the back, often accompanied by unyielding nausea. Treatment involves keeping the patient completely fasting to rest the organ, managing their extreme pain, and providing large volumes of intravenous hydration. Bowel infarctions occur when the blood supply to the intestines is cut off, causing the bowel tissue to literally die and rot inside the abdomen. This dead tissue releases a huge load of bacteria and toxins directly into the bloodstream, quickly leading to overwhelming sepsis and shock. The patient will experience agonizing abdominal pain that seems entirely out of proportion to what you feel when you gently press on their stomach. This is an absolute surgical emergency, and the dead portion of the bowel must be physically removed to save the patient's life. Sometimes, the pressure inside the abdominal cavity becomes so high that it squeezes the internal organs and stops blood flow, creating a condition called abdominal compartment syndrome. This can happen after aggressive fluid resuscitation, major bowel swelling, or complicated abdominal surgery. As the stomach stretches, it pushes up against the diaphragm, making it incredibly difficult for the ventilator to push air into the lungs. The physician may have to surgically open the abdomen at the bedside to release the trapped pressure and restore blood flow to the dying organs. Providing nutrition is a core component of critical care, and we always prefer to use the gut if it is working properly. Enteral feeding, or providing liquid nutrition through a tube into the stomach, helps keep the intestinal lining healthy and prevents bacteria from leaking into the bloodstream. You must always confirm the feeding tube is properly placed with an X-ray before starting the liquid formula to ensure you are not accidentally pouring food into the lungs. Monitoring for tolerance, such as checking for nausea or abdominal bloating, ensures the patient is digesting the calories safely. Managing these three systems requires you to think broadly because an intervention for one organ often directly impacts another. For example, giving heavy fluids to fix the kidneys might inadvertently raise the pressure inside the brain if the patient happens to have a head injury. You must constantly balance these competing priorities, watching your lab values and physical assessments to ensure you are helping the whole patient. This ability to see the bigger picture and anticipate unseen complications is the true hallmark of an expert critical care nurse. Congratulate yourself for completing this complex section on the neurological, renal, and gastrointestinal systems. I strongly encourage you to complete the attached practice test right now to apply the knowledge you just gained. Answering realistic practice questions greatly improves your retention and provides a true measure of your exam readiness. The quiz included with this lesson is designed to promote active learning and help you think critically about these overlapping emergencies. Keep this excellent momentum going as we naturally transition into the next section, where we will conquer the endocrine, hematology, immunology, and integumentary systems. Welcome to the fourth part of this training, covering the endocrine, hematology, immunology, and integumentary systems. In this module, you will discover how to manage blood disorders, hormone imbalances, allergic reactions, and deep burns. Grasping these concepts is vital because these systems act as the body's hidden defense and regulation mechanisms during times of high stress. Prepare to uncover the chemical signals and cellular battles happening inside your most vulnerable patients. Let us dive into the fascinating world of hormones and blood cells. The endocrine system functions as an advanced communication network that uses hormones to control almost every cellular process. When a patient enters an intensive care environment, their physical stress response triggers a large release of these chemical messengers. This sudden surge often leads to wildly fluctuating blood sugar levels, even in people who have never been diagnosed with diabetes. You must continuously monitor these glucose trends, as both extreme highs and extreme lows can cause rapid brain damage. Diabetic ketoacidosis is a life-threatening complication that primarily affects individuals with type 1 diabetes when they completely run out of insulin. Without insulin, sugar cannot enter the cells to provide energy, forcing the body to break down fat for fuel instead. This fat breakdown process creates toxic byproducts called ketones, which turn the blood dangerously acidic. Patients will present with a fruity odor on their breath and a deep, rapid breathing pattern as they try to exhale the excess acid. Treating this acidic state requires a continuous intravenous infusion of regular insulin to help drive glucose back into the starving cells. As insulin pushes sugar into the tissue, it also drags potassium along with it, causing serum potassium levels to plummet rapidly. Therefore, you must closely watch the cardiac monitor and frequently replace electrolytes to prevent lethal arrhythmias. You will also administer large volumes of normal saline to flush out the ketones and rehydrate the profoundly depleted vascular space. A similar but distinct emergency is the hyperosmolar hyperglycemic state, which mostly strikes older patients living with type 2 diabetes. These individuals still produce a tiny amount of insulin, which prevents the formation of ketones and keeps the blood from becoming acidic. However, their blood sugar can rise to staggering numbers, sometimes exceeding 1,000 milligrams per deciliter. This incredibly thick blood acts like a diuretic, forcing the kidneys to excrete massive amounts of water and leading to profound cellular dehydration. The primary treatment for this hyperosmolar condition focuses heavily on aggressive fluid resuscitation to restore total body water. You will give liters of intravenous fluids to dilute the concentrated blood and support dropping blood pressures before focusing heavily on insulin. While an insulin drip is still necessary, the dose is generally lower than what is required for ketoacidosis. Returning the glucose level to normal must happen slowly to avoid causing a sudden shift of water into the brain, which causes fatal swelling. Diabetes insipidus is a completely different endocrine disorder involving a lack of antidiuretic hormone, which normally tells the kidneys to hold onto water. Without this hormone, the kidneys continuously dump completely clear, dilute urine, sometimes exceeding a liter every hour. This rapid fluid loss leaves the remaining blood highly concentrated, causing a dangerous spike in serum sodium levels. You will treat this by administering synthetic hormones, like desmopressin, to stop the excessive urination and carefully replacing the lost free water. The exact opposite problem occurs with the syndrome of inappropriate antidiuretic hormone, where the brain releases far too much of this holding chemical. The kidneys respond by reabsorbing nearly all water back into the bloodstream, creating a state of severe fluid overload. This extra water dilutes the blood, dropping the serum sodium concentration to dangerously low levels. Management involves strictly limiting the amount of fluid the patient can drink and sometimes administering hypertonic saline to safely correct the sodium imbalance. Shifting to hematology, Disseminated intravascular coagulation is a catastrophic bleeding disorder triggered by extreme systemic stress, like sepsis or major trauma. In this chaotic state, the body inappropriately turns on all its clotting factors at once, forming thousands of tiny blood clots throughout the smallest vessels. These microvascular clots block oxygen delivery to organs, causing the kidneys and liver to begin failing simultaneously. The tragic irony of this condition is what happens next. Because the body has foolishly used up all its available clotting factors, making those tiny blockages, there is nothing left to stop normal bleeding. The patient will suddenly begin oozing blood from their intravenous sites, their gums, and their gastrointestinal tract. Managing this crisis is incredibly complex, as you must treat the underlying cause while simultaneously giving blood products to replace what was lost. You are walking a tightrope between preventing further clots and stopping the active, widespread hemorrhage. Heparin-induced thrombocytopenia is another serious blood disorder that occurs as a strange allergic reaction to a common blood-thinning medication. After receiving heparin for a few days, the patient's immune system accidentally creates antibodies that attack their own blood platelets. These damaged platelets clump together, creating dangerous new clots while the overall platelet count drops significantly. You must immediately stop all heparin exposure and switch to a different class of anticoagulant to prevent deep vein thromboses or strokes. Moving into immunology, anaphylaxis represents the worst type of allergic reaction you will encounter in clinical practice. When a hypersensitive patient is exposed to a specific trigger, like a bee sting or a certain antibiotic, their immune system completely overreacts. This response releases a flood of histamine, causing the blood vessels to immediately relax and the airway passages to tightly constrict. The patient will experience a sudden drop in blood pressure, wheezing, and visible swelling around their face and lips. The absolute priority in treating anaphylaxis is the immediate intramuscular injection of epinephrine. This powerful drug works instantly to tighten the relaxed blood vessels and force the constricted airways back open, reversing the worst symptoms. You will also administer supplemental oxygen, fast-acting antihistamines, and steroids to calm the underlying immune storm. Time is of the essence, as a swollen airway can close completely within minutes if not treated aggressively. Many patients in the intensive care unit are medically immunosuppressed, especially those who have recently received a solid organ transplant. These individuals must take specialized daily medications to prevent their bodies from attacking and rejecting the new heart, kidney, or liver. Because their defenses are artificially lowered, they are incredibly vulnerable to opportunistic infections that a healthy person would easily fight off. Strict hand hygiene and isolating the patient from sick visitors are non-negotiable steps in their daily care plan. Our final topic covers the integumentary system, focusing specifically on thermal injuries. The skin is the largest organ of the body, providing a crucial barrier against bacteria and keeping essential moisture trapped inside. When a large percentage of this tissue is destroyed by fire or chemicals, the patient instantly loses their ability to regulate temperature and hold onto fluid. Deep burns require specialized center care, as the risk of overwhelming infection is extraordinarily high. In the first 24 hours after a major thermal injury, the damaged blood vessels become highly permeable, leaking protein and plasma out into the surrounding tissues. This huge fluid shift leaves the circulatory system dry, plunging the patient into a specialized state called burn shock. Your primary intervention during this initial phase is calculated fluid resuscitation based on the total body surface area affected. You will meticulously track hourly urine output to determine if your intravenous fluid rates are effectively supporting the kidneys. As all that leaked fluid builds up in the damaged tissues, it creates significant swelling that can cut off circulation entirely. If a deep burn circles completely around an arm or a leg, the tough, burned skin acts like a rigid tourniquet as the tissue underneath expands. This prevents fresh arterial blood from reaching the hands or feet, threatening the survival of the limb. The physician may perform an escherotomy, which is a surgical cut directly through the burned skin to release the pressure and restore flow. If a patient was trapped in an enclosed space during a fire, you must assume they have an inhalation injury until proven otherwise. Breathing in superheated air and toxic smoke quickly damages the delicate tissues of the throat and lungs, leading to rapid airway swelling. Even if the patient is talking normally upon arrival, their vocal cords can close completely within a few hours. Early placement of a breathing tube is often the safest strategy to secure the airway before the swelling makes intubation impossible. Once the initial shock phase has passed, burn management shifts toward extensive wound care and infection prevention. The dead skin must be scrubbed and removed daily to allow healthy new tissue to grow, which is an agonizingly painful process requiring heavy sedation. Because the protective skin barrier is gone, sepsis remains the leading cause of death for burn victims who survive the first few days. Vigilant temperature monitoring and strict sterile techniques during dressing changes are your best tools against microscopic invaders. Congratulate yourself for finishing this detailed section on the endocrine, hematology, immunology, and integumentary systems. I strongly encourage you to complete the attached practice test right now to secure these ideas in your mind. Answering related practice questions actively improves your retention and gives you an honest measure of your exam readiness. This helpful quiz is included with this lesson to ensure you grasp these concepts before moving forward. Keep your energy high as we smoothly transition into the next segment, where we will tackle multi-system organ failure, shock states, and trauma. Welcome to the fifth section of our complete study guide, where we will bring all your knowledge together to tackle multi-system organ failure, shock, and major trauma. In this crucial lesson, you will learn how to identify systemic collapse, quickly initiate massive resuscitation protocols, and stabilize the most critically ill patients imaginable. Understanding these extreme medical emergencies is absolutely essential, because this is where your quick thinking truly means the difference between life and death. Get ready to connect everything you have learned so far, because this section will elevate your clinical reasoning to an expert level. Let us jump right into the intense world of shock. To truly understand any type of shock, you must zoom in closely and look at what is happening at the cellular level. Shock is simply a state where the body is failing to deliver enough oxygen to the tissues to meet their daily metabolic demands. When cells do not get oxygen, they are forced to switch to anaerobic metabolism, which creates a toxic buildup of lactic acid. If this cellular starvation is not reversed quickly, those individual cells will die, leading to tissue damage, organ failure, and eventually the death of the patient. Hypovolemic shock is the most straightforward type to understand, as it occurs when there is simply not enough fluid circulating inside the blood vessels. This profound volume loss is usually caused by extensive bleeding from a trauma, but it can also result from severe dehydration or deep burns. The patient will present with a racing heart rate as the body desperately tries to circulate the little blood it has left. Your immediate intervention is to aggressively fill the tank back up using rapid intravenous fluids and emergency blood products to restore that lost volume. Distributive shock is a fascinating category where the patient has plenty of fluid, but their blood vessels have inappropriately dilated and become far too wide. Imagine water flowing through a garden hose, and suddenly that hose expands to the size of a firehouse, causing the water pressure inside to instantly drop to zero. Because the container is now too large for the fluid inside it, the blood pools in the extremities and cannot return to the heart. To fix this dangerous loss of pressure, you will rely heavily on vasopressor medications to squeeze those widened vessels back to their normal size. Neurogenic shock is a unique type of distributive shock that typically occurs immediately after a devastating injury to the spinal cord. This trauma severs the communication lines between the brain and the blood vessels, resulting in an instant loss of sympathetic nervous system tone. Without these vital nerve signals, the blood vessels instantly relax, and the blood pressure drops dangerously low. What makes neurogenic shock unique on the exam is that the patient will actually have a very slow heart rate, because the sympathetic nerves that normally speed up the heart are also disconnected. Septic shock is the most common and complex type of distributive shock you will manage in the intensive care unit. It begins with a localized infection, like pneumonia or a urinary tract infection, that accidentally triggers an overwhelming inflammatory response across the entire body. This widespread inflammation causes blood vessels to widely dilate and become highly permeable, allowing precious fluid to seep out into the surrounding tissues. The patient will look deeply flushed, their fever will spike, and their blood pressure will plummet as their vascular system rapidly collapses. Because sepsis progresses so quickly, hospitals utilize strict, time-sensitive protocols known as sepsis bundles to save lives. The moment you suspect sepsis, your immediate priority is to draw blood cultures to identify the specific bacteria causing the infection. Crucially, you must draw these cultures before you give any antibiotics, because giving the drugs first will destroy the bacteria in the sample and ruin the lab results. Once the cultures are collected, you will immediately hang broad-spectrum intravenous antibiotics to start fighting the infection while you wait for the final laboratory report. Along with rapid antibiotics, fluid resuscitation is a cornerstone of the Surviving Sepsis Campaign guidelines. The standard protocol requires you to administer an aggressive fluid bolus, typically calculated at 30 milliliters per kilogram of the patient's body weight. This large volume of crystalloid fluid is pushed quickly to fill up the dilated, leaky blood vessels and restore a safe blood pressure. You will then closely monitor the patient to see if their blood pressure and urine output improve, which tells you if the fluids are successfully reaching the organs. If you have given the required fluid boluses and the patient's blood pressure is still dangerously low, they have officially entered septic shock. At this critical point, you must start continuous intravenous vasopressors, with a medication called norepinephrine almost always being your first choice. Norepinephrine works powerfully to squeeze the completely relaxed blood vessels, forcing the pooled blood back toward the heart and vital organs. You will carefully titrate this continuous drip minute by minute to maintain a target mean arterial pressure of at least 65 millimeters of mercury. Moving to a completely different category, obstructive shock happens when a physical blockage prevents the heart from pumping blood forward. A classic example is a tension pneumothorax, where air escapes from an injured lung and becomes permanently trapped inside the chest cavity. As this trapped air builds up, it creates immense pressure that physically squishes the heart and the major blood vessels, entirely stopping blood return. This is an extreme emergency that requires the physician to instantly decompress the chest with a large needle to release the trapped air. Cardiac tamponade is another deadly form of obstructive shock where blood or fluid rapidly fills the tough, fibrous sac surrounding the heart. This fluid physically chokes the heart muscle, preventing the chambers from expanding and filling with blood between each beat. You will identify this emergency by looking for Beck's triad, which consists of muffled heart sounds, distended neck veins, and a dangerously low blood pressure. The only way to save the patient is for a doctor to insert a long needle through the chest wall and drain the restrictive fluid from around the heart. When a patient arrives after a major physical trauma, your assessment must be incredibly fast and perfectly structured to catch hidden injuries. You will always begin with the primary survey, strictly following the alphabet order of airway, breathing, circulation, disability, and exposure. You must first ensure their airway is open while simultaneously protecting their cervical spine from movement in case their neck is broken. Only after you secure the airway and ensure they are actually breathing will you move on to stopping heavy bleeding and checking their blood pressure. In severe trauma cases with uncontrolled bleeding, simply giving normal saline is dangerous because it dilutes the patient's remaining blood and washes away the clotting factors. Instead, you will initiate a massive transfusion protocol, which replaces exactly what the patient is bleeding out onto the floor. This protocol dictates giving packed red blood cells, fresh frozen plasma, and platelets in an exact 1:1:1 ratio. This balanced ratio mimics whole human blood, keeping the patient's blood pressure up while still providing the essential factors they need to physically form a clot. When the body sustains any huge insult, whether from traumatic injury, significant burns, or complex surgery, it often develops systemic inflammatory response syndrome. This is a state of hyperinflammation where the immune system remains stuck in overdrive, causing high fevers, elevated white blood cell counts, and a racing heart rate. While this syndrome looks highly similar to sepsis, the key difference is that it is caused by an injury or inflammation, not an actual bacterial infection. Managing this condition involves treating the underlying injury and supporting the patient's skyrocketing metabolic demands. If shock or severe inflammation is not reversed, the patient will inevitably progress into multiple organ dysfunction syndrome, commonly referred to as MODS. This is a devastating chain reaction where organs that were previously perfectly healthy begin to rapidly fail one after the other. The lungs are usually the very first organ to collapse, rapidly followed by the kidneys, the liver, and eventually the gastrointestinal tract. Once multiple organs begin failing, the mortality rate skyrockets, making early intervention during the initial shock phase absolutely critical. Caring for a patient in multisystem organ failure requires maximum critical care support and an incredibly watchful eye for subtle changes. These patients will require a mechanical ventilator to breathe, continuous dialysis to clean their blood, and multiple vasopressors to keep their heart pumping. You must meticulously track every single drop of fluid entering and leaving their body, as their system can no longer balance water on its own. Your goal is to provide perfect supportive care, buying the damaged organs enough time to rest and slowly heal themselves. In these severe shock states, continuously monitoring the lactic acid level in the blood is one of your most valuable assessment tools. Because lactic acid is produced when cells are starving for oxygen, a rising level tells you that your current treatments are failing to perfuse the tissues. Conversely, if you see the lactic acid number steadily dropping after you administer fluids and oxygen, you know your interventions are actually working at the cellular level. This simple lab value provides a perfectly clear window into how the invisible, microscopic cells are tolerating the current crisis. Nutrition is easily forgotten during a chaotic shock resuscitation, but it is completely vital for survival and preventing further organ damage. The severely stressed body consumes large amounts of calories to fight infection and repair damaged tissues, quickly burning through all stored energy. Starting early feeding through a tube placed into the stomach helps protect the fragile lining of the intestines and prevents gut bacteria from leaking into the bloodstream. You must advocate for early nutrition as soon as the patient's blood pressure is somewhat stabilized with medications. Managing severe shock and trauma requires intense communication with the patient's family, who are often experiencing the absolute worst day of their lives. You must provide them with honest, clear updates about the failing organs without taking away all their hope. In cases where the organ damage is irreversible and treatments are no longer working, you will help the family transition toward palliative or end-of-life care. Providing compassionate support during these tragic moments is just as important as managing the complex machines keeping the patient alive. Congratulate yourself on making it through this incredibly intense section on multi-system organ failure, shock, and severe trauma. I enthusiastically encourage you to complete the attached practice test, because working through complex scenarios is the absolute best way to measure your exam readiness. Doing these practice questions builds your clinical reasoning skills, improves your overall retention, and proves you can handle difficult topics, which is why the quiz is included with this lesson. Please maintain this fantastic focus and active learning mindset, as we will naturally transition into our sixth and final section next. End your study session today knowing you are doing an amazing job preparing for your certification exam. Welcome to the final section of your study guide, focusing on professional caring, ethical practice, and test strategy. You will discover how the Synergy model guides patient care, explore nursing ethics, and learn techniques to dissect complex questions. Grasping these concepts is required to pass the test and become an excellent practitioner. Get ready to conquer the exam with total confidence. Let us finish this journey strong. The foundation of the CCRN exam is the AACN Synergy model for patient care. This framework states that the needs of the patient must drive the specific competencies of the nurse. When the abilities of the nurse perfectly match the requirements of the individual, the best possible outcomes occur. You must view every question on the test through the lens of this model. Patients possess unique characteristics that fall along a continuum of severity. These traits include resilience, vulnerability, stability, and predictability. For instance, a trauma victim is highly vulnerable and completely unpredictable. You must assess where your patient falls on this spectrum to provide the correct level of support. To meet those diverse needs, nurses must demonstrate defined competencies. These skills include clinical judgment, advocacy, moral agency, and systems thinking. If a patient becomes severely unstable, you must use high-level clinical judgment to keep them safe. The exam will repeatedly ask you to identify which nursing skill best addresses a specific patient need. Advocacy is a core nursing responsibility heavily tested on this certification. To advocate means to protect the rights, values, and beliefs of the patient when they cannot speak for themselves. This might involve questioning a medical order that seems unsafe or ensuring a family understands a complicated diagnosis. You are the final line of defense for the individual resting in that bed. Moral agency involves recognizing ethical dilemmas and taking action to resolve them. You will encounter situations where treatments cause pain but offer little hope for recovery. As a nurse, you must navigate these conflicts by relying on established ethical principles like autonomy and beneficence. Autonomy respects the right of the patient to make their own healthcare decisions. Beneficence requires you to act in ways that benefit the patient. Non-maleficence is the obligation to do no harm. Sometimes, these two principles conflict during aggressive medical interventions. You must constantly evaluate whether the therapies you deliver are truly helping the person or simply prolonging the dying process. End-of-life care is a guaranteed topic on your test. When a family decides to withdraw life support, your focus shifts entirely from curing to providing comfort. You will administer medications to eliminate pain and ease breathing difficulties. Providing a peaceful, dignified death is one of the most profound duties you will perform in your career. Effective communication with families is another major testing area. Relatives of the critically ill experience extreme stress and often struggle to comprehend medical jargon. You must provide clear, honest updates using simple language. Supporting the family is a direct extension of caring for the patient. Cultural competence ensures you respect the diverse backgrounds of the people you treat. Individuals from different cultures have varying beliefs regarding illness, pain management, and death. You must assess these preferences and integrate them into your care plan. Ignoring cultural needs violates the core principles of the synergy model. Now let us pivot to exam strategies, starting with how to read the questions. You must read every single word carefully because a single modifier can change the entire meaning. Words like first, best, most, or initial dictate what you must do before anything else. Never skim the prompt, or you will miss the key piece of information needed to answer correctly. Always rely on the nursing process when deciding your next action. If the question states the patient experiences a sudden change in condition, your first step is always to assess. Do not choose an intervention, like giving a medication, until you have fully evaluated the situation. Assessment answers are usually correct when you lack enough data to act. When forced to prioritize among multiple problems, fall back on airway, breathing, and circulation. A blocked airway will kill the patient much faster than a low blood pressure. Always fix the breathing issue before addressing a circulation problem. This hierarchy will guide you through the most confusing priority questions. Patient safety is the ultimate priority for the test writers. If an answer choice places the individual at risk, it is absolutely wrong. Conversely, if an option prevents harm, it is very likely the correct choice. Always ask yourself which action keeps the person furthest away from danger. Avoid answer choices that involve passing the responsibility to someone else. The exam wants to know what you, the critical care nurse, will do in the moment. Calling the doctor is rarely the best initial action if there is an independent nursing intervention you can perform first. Take ownership of the situation. Physical needs almost always take priority over psychosocial needs on this test. While holding the hand of an anxious patient is good practice, restoring their dropping oxygen level keeps them alive. You must secure their physical stability before addressing their emotional distress. Focus on the physiology first. You must separate how things happen in your specific hospital from textbook reality. The exam is based on ideal, evidence-based practices, not the shortcuts that occur in the real world. Answer the questions based strictly on what the official guidelines dictate. Leave your everyday workplace habits at the door. Managing your time during the test is a skill you must practice. You have a limited number of minutes to answer a large volume of questions. Do not get stuck staring at a single problem for 5 minutes. If you do not know the answer, make an educated guess, mark it for review, and move forward. Finally, learn to trust your initial instincts. Statistically, your first guess is usually correct because it comes from your subconscious clinical knowledge. Do not go back and change your answers unless you discover a clearly missed detail in the prompt. Second-guessing yourself usually leads to changing a right answer into a wrong one. Congratulate yourself for completing this entire course. I encourage you to take the attached practice test immediately to gauge your readiness. Answering practice questions locks in your knowledge and familiarizes you with the exam format. The included quiz will help you practice active learning and highlight any remaining weak areas. You are now fully equipped to succeed, so go pass that exam.